Thank you very much for inviting me today to give this talk. I said very much this is going to be a bit of a change of theme here. It really is very much research focused, and that reflects the fact that, first of all, I am a researcher, but also it really reflects the state of play of liquid biopsies. Really, there are very few that have made it into the clinic so far, so most of where we are is still at that research level. So just to give you an overview of my talk, I'm going to just give you a brief overview of actually what are liquid biopsies, then a little bit of introduction about ovarian cancer, then the strategy that we have employed at Queen's to address and try and identify some novel liquid biopsy options, and then where we are in trying to actually make these a reality. So I don't think I need to tell the room here how important it is to collect a sample when we're looking at either the diagnosis or the clinical management of cancer. Really, these samples can act as a molecular proxy of giving us an idea of the overall disease status. And really, as we're moving into this era of personalised medicine, we can use biomarkers to really try and help us understand the underlying biology of any disease and use that information to really tailor the treatment to the individual and make it a proper personalised management plan. Obviously, traditional biopsies or traditional collection of tumour samples has relied on either a biopsy or a surgical resection. And this, while it has obviously served its purpose for a long time, it does have limitations. The first of which is obviously accessibility, and while it's all well and good to having a surgery to access that sample, if you need to go back in, it isn't quite so simple. We also then obviously have issues over tissue quality, preservation, and obviously heterogeneity. If we were taking a tiny sample, how well does that reflect the rest of the whole disease? So it's thought that liquid biopsies really can overcome some of these limitations. So what are they? Liquid biopsies are a way of measuring circulating biomarkers. And I think most of us will, if we think about liquid biopsies, we'll think about blood, but actually it can be any biofluid. Got some examples here. We can collect it from like saliva, from pleural effusions, from urine. It can be sweat, it can be tears. Really, the options are limitless. It's really, it will come down to our technology in the future. And as I said, the advantage of these biofluids is they are technically limitless. They are easily accessible and for the most part minimally invasive. Obviously some will be slightly more involved than others. But this minimal invasiveness and the fact that we can collect them readily and easily will have much impact on the cost, not only to the patient but also to the health service. If we can collect information from a simple blood draw that maybe can even be done in a GP's office, a nurse's office, this means we're not into this scenario where we need a radiologist to help guide our the biopsy collection. The other thing, obviously, with liquid biopsies, it means we can do this repeat analysis. It means we can monitor patients longitudinally. This means that we can use it to screen patients, to hopefully mean that we are at the stage where we're actually going to be collecting or detecting cancer or detecting any disease before it really has a chance to take, and it means we can really make an impact. It also means, though, if treatment is detected, or if disease is detected, we can look at best ways of treating. We can stratify our patients. Then, following any of that treatment, we can monitor response and obviously look for minimal residual disease coming back up, and again, tailoring the treatment right from the get-go. So, what can be measured in a liquid biopsy? Well, there's three main forms. We've got the circulating tumour cells, and obviously as the name gives it away, these are tumour cells that are circulating around the body. They're either shed actively or passively by the tumour cell, and they are thought to be the seeds for metastasis. In terms of clinical use, there is actually one approved diagnostic tool from Janssen called CancerSeek that can be used to detect and enumerate CTCs. But that's as far as it can go. It will detect the number of them, and this can have prognostic information, but there is no further downstream analysis of these CTCs. The next type of liquid biopsy looks as exosomes, and these are these tiny vesicles that again are shed from the cancer cell and can harbour lots of information from that cancer. And then the final type is the cell-free DNA, which encompasses the circulating tumour DNA. So using these liquid biopsies, what can we measure? What can we detect? And you can see actually there's a huge range of things we can look at. Obviously we can look at mutations and look at point mutations, translocations, all of this information. We can also look at epigenetic regulation and transcriptomics. What's interesting as well is from our circulating tumour cells, we can actually do phenotypic studies. So we can collect these, the possibilities are that we can collect these CTCs, grow them up in the lab and actually treat them with the drugs and see, can we predict how a patient's going to respond? And there's also lots of other things we can do. The interesting thing is you can see that depending on what our application is, different forms of liquid biopsies are obviously more advantageous. And one of the things that I find very interesting from a research point of view is to think what are the liquid biopsies that we can look at from biobanked samples, from frozen samples. Because obviously in the development of this, we need to first of all do all of our retrospective studies. So that's where probably the cell-free DNA and exosomes is more advantageous, that we can access that from our frozen samples. So for this talk, I'm mainly going to focus on the cell-free DNA. It's probably the most advanced, as I said, in terms of liquid biopsies. And I said it also encompasses the circulating tumour DNA. But I said not all cell-free DNA is going to be from the tumour, and that is a really important technical factor that we'll come back to later. So what is cell-free DNA? Essentially, it's really short fragments of DNA. I said there are about 150 to 180 base pairs, so really small little fragments. And I think the length of that is actually reflecting that kind of secondary and tertiary structure of DNA where it's wrapped around the histones, and it's obviously being cut up where it is actually free. It is more abundant than CTCs. They reckon in a ml of blood you can isolate maybe between 1 and 10 CTCs. Now exosomes are much more abundant. There's possibly billions per ml. So we're somewhere in between that with our cell-free DNA. So there is enough of it around, but as I said, it's not huge. And as I said, the advantage I think in terms of its development is the fact that it can be accessed and it can be analysed in frozen plasma. So where does this cell-free DNA come from? Well, basically any cell in the body can shed DNA. It's when the cell is turning over, it's just dying, there's apoptosis, necrosis, that DNA is released into the system. And as said before, this is all cells, not just tumour cells. In terms of liquid biopsies actually moving into practice, there are a number of FDA-approved liquid biopsies. The first of which was the COBAS test for EGFR mutations, which is obviously the companion diagnostic for drugs like Tarceva and gefitinib. And this really is a transition from the previously tissue-based assay, looking for these EGFR mutations, and moving it now into a blood-based assay. Now, while it is approved and it is offered, there is still a little bit of hesitation in that if you get a negative result, if you cannot detect a mutation from the liquid biopsy, it is still recommended that you will then go and confirm that in a tissue biopsy. So we've kind of got the specificity is okay, but the sensitivity isn't great still. Again, as said, there is limited examples in clinical utility at the moment, but there's a lot more examples coming up through from a research point of view. And I think everybody would have seen the headlines this year of this new CancerSeq test. It was published obviously in Science Translational Medicine. And it seemed to be an amazing concept, an amazing idea that we'd have a simple blood test that could detect up to 8 different common cancers. And it said it looked at the mutations of about 16 different genes, and also along with this, they also looked at 8 different circulating proteins. The overall sensitivity was pretty good at about 70%. As I said, this obviously varied depending on diseases. As I said, breast was one of the lowest, down at about 38%, while ovarian was quite high. But then if you looked at the early stages of the disease, it started dropping off. This sensitivity really did drop. The other important kind of caveat of this study is that there was no normal patients included, I mean non-cancerous patients included in this study. So they could not test the specificity. Every patient in the study did have cancer. So really, you know, if we were wanting to implement these, and the real idea of this is that it would be a screening tool, it's, you know, you need to actually include non-cancerous patients in the development. But really what you can see from this is there is huge potential, and this has been reflected in the amount of money invested. You know, in the US there you can see over $1 billion has been invested in companies developing this sort of technology. And I think as well this has been highlighted by a recent joint report from ASCO and CAP, the Pathology College, that was published in the Journal of Clinical Oncology. And they have said that there is they recognize the potential, and they say there is good evidence, or at least some evidence, of the validity and clinical utility in the metastatic setting, but they really have pointed out that there is pretty much no evidence in the early stage disease. Now this report is not negative. In fact, they end on a very positive note and say that they acknowledge that this field is moving so fast that we're going to have to review this all the time. It isn't as though they've just said no to liquid biopsies and shelved it. And I do think that the technology is moving so fast that come back in a year's time and this could have changed. So that's kind of my introduction to liquid biopsies, a pretty fast introduction. So I'm going to move on now to ovarian cancer, and again, just very brief overview. As said, ovarian cancer is the third most common gynecological malignancy after uterine and cervical, but it is the most lethal. In fact, every day 11 women are dying in the UK from ovarian cancer. And this is probably underpinned by the fact that, first of all, when you have the disease, it is quite resistant to a lot of chemotherapies, but probably the single most important factor is 60% of women who are diagnosed with ovarian cancer are already at stage 3 or above. So this has huge impact on your prognosis. And these are some stats from the Northern Ireland Cancer Registry. And you can see here, you know, if you're diagnosed at stage 1, you've got an excellent chance. Your overall survival is excellent, but this is dropping very significantly as we go up through our stages. And while these stats, you can see they're 10 years old, in fact, the overall survival of ovarian cancer really hasn't changed in the last 30 years. And this is despite advances in surgery, despite advances in treatment. And this is because we are still diagnosing it too late. So really the only way we are going to make a difference for ovarian cancer is by diagnosing it as early as possible. So I think any talk about liquid biopsies and any talk about ovarian cancer, we can't not mention CA125. I said it's probably one of the best known liquid biopsies, protein markers, serum markers, along with PSA. And I said it is used routinely in the management of ovarian cancer. The issues with it, though, however, is that it is not always elevated in early ovarian cancer. 50% of early cases do not have elevated CA125. Furthermore, CA125 can be elevated for non-malignant reasons, just if there's some form of inflammation. So it means from a screening point of view, it is not fit for purpose. And this has been shown by two really large UK and US studies where they combined CA125 with pelvic ultrasound and just shown that it did not help in the screening. So we really do need to try and find some new ways of screening and being able to diagnose ovarian cancer as early as possible. The symptoms are quite, diffuse and, not very specific. So we need to have a test that really we can apply. There's been obviously lots of research into this area, and this is just a summary from a paper just this year highlighting some of the research and studies in cell-free and circulating tumour DNA for ovarian cancer. And you can see this has been in lots of different areas. There's been actually just quantification of how much cell-free DNA there is. And again, this is linked to prognosis. There's also looking at mutations, chromosomal abnormalities, as well as methylation. So there really is lots of different ways of looking at it. And again, there's lots of different applications. I said, I know my eyesight isn't that good, but hopefully you guys can see some of this. But it is looking at different applications from early detection as well as more patient stratification. One thing you'll notice is that most of these are actually blood-based, and most of these are plasma-based. And that's thought that even though you actually get higher amounts of cell-free DNA from serum, it's actually when during the processing you get a lysis of leukocytes, which will release a lot of DNA in it, which can maybe swamp the system. So it is probably better to go from plasma. But that's not to say that blood is the best way for looking at ovarian cancer. And again, this is a study that was just published in Science Translational Medicine this year as well, looking using liquid biopsies or liquid from biofluids from pap smears. And they had a look at diagnosis of both ovarian cancer and endometrial cancer. And again, they looked at different genes, different mutations, as well as aneuploidy. And it was quite good at detecting endometrial cancer, not quite so good at ovarian cancer. If you combined it with the presence of ctDNA, this increased. But again, while it was low sensitivity, they did actually include non-cancer patients in this, so they could show very good specificity. And while there's still a long way to go with this, I think it really highlighted the potential of applying any of these to the diagnosis of ovarian cancer. So as I said, this is an area that we're very interested in Queen's, and there's two main groups interested in this. It's my group and then also Paul Mullins. And really this has been a collaborative effort. I wouldn't be doing it without him and without our collaboration with all of our clinicians within the cancer centre at Belfast City Hospital. And we focus mainly on a type of ovarian cancer called high-grade serous cancer. And you'll understand why I have the ovarian in brackets now in a minute. So this is the most common and aggressive form. And as I said, in recent years, it's become evident that the fallopian tube is actually the cell of origin of these cancers, not the ovary. So there has been a change in the nomenclature to move away from calling it high-grade serous ovarian cancer. There's lots of pelvic non-uterine words, and there's lots of acronyms, but we just stick to high-grade serous to make it easier. And when we were studying this, we were very lucky that one of our clinical fellows worked very closely with Glenn McCluggage, who I think is the leading ovarian cancer pathologist in the world, or one of them at least. And James produced this very bespoke clinical cohort. It's very small, but perfectly formed. It was from 6 patients, and we had matched tissue from the normal fallopian tube, stick, which is the very earliest precursor lesion of ovarian cancer, the actual cancer themselves, as well as omentum, obviously the metastasis, and also normal ovary. And we had, as I said, lots of it. We have matched tissue from this, as well as DNA and RNA. And we've used this cohort to try and identify novel biomarkers that can be used in this for either the diagnosis or the management of ovarian cancer. And we decided to take the approach to look at epigenetics in terms of biomarkers. So why would you want to do this? Well, first of all, their epigenetic changes are very stable. They're stable in samples. They also have very good frequency, and you would think, most people turn around and say, why aren't you looking at mutations? Sure, 95% of ovarian cancers have a P53 mutation. But actually, yes, they might have that, but it's not the same mutation. In fact, it can cover, like a P53 mutation can be across a span of exons that can actually cover up to 20 kilobases of DNA. So it's not so easy to kind of go after that in multiple patients. So as I said, methylation or epigenetic changes are much more stable and much more common and simple in cancer. As I said, they also, as we saw before, they have the potential to be accessed through liquid biopsies. They are also reversible, which means that actually we can use them to assess in real time the status of any disease. And there is also potential down the road at them actually being used as a target themselves. Again, we decided to look at then methylation as a form of epigenetics. It's the most widely studied form of epigenetics. And as I said, it's the addition of a methyl group onto a cytosine that's preceded by a guanine. And they're highly concentrated. These sort of methylation events and these CpG islands are highly concentrated within the promoter or near the first exon of any gene. And this thought to play a very important role in gene expression, either opening up the DNA to allow transcription or closing it down. And this plays a really key role in cancer in that overall you see global hypomethylation, so you see loss of methylation, which just means lots of genes get turned on in a deregulated fashion. But you also more see specific hypermethylation at tumor suppressors to turn them off. Also, there has been clinical utility shown for studying methylation. In fact, the FDA have approved its first methylation-based liquid biopsy for screening for colon cancer, and this is the EpiProColon test, which is based on the methylation of a gene called septin-9. And this gene was discovered, or this methylation mark was discovered where they went specifically looking for a liquid biopsy marker. So it's quite a little, their methodology is slightly different to the way we've gone after things. So how do you find a potential liquid biopsy or a methylation mark? So what we've done is take the approach of doing our discovery in the tissue and validating these in tissue, and we're now at the stage of trying to migrate these to liquid biopsy. And really this is down to the accessibility of the samples that we had. And I said we've taken two approaches, the candidate gene approach, which has really been my focus, while Paul Mullen's group have taken a more global approach and used some methylomics to have a look at it. So I'm going to tell you a little bit about the candidate gene approach. Unfortunately, we are in the process of trying to file this for patent, and I hoped I would have been further along. So I am not able to tell you very much. I'm not allowed to tell you the name of the gene. If I accidentally say it, I may have to get David Mead to help hypnotize you all tomorrow and blank it all from your memory. It also means that I can't really reveal much of my data, but believe me, it's amazing and you'd all be blown away. So just use your imagination that it's the best data you've ever seen. So essentially, we in our lab have identified this novel oncogenic driver of ovarian cancer. Basically had no link to ovarian cancer or even any cancer alone at all. And it's, we looked in some of the online, the big TCGA cancer databases, and when we looked at just even copy number variations and gene expression alterations in this gene, it's altered in up to 15% of ovarian cancer cases, and it's part of a family that shows alterations in up to about 60%. And I said, if you remember, this TCGA is obviously only looking at certain aspects. So we've had a look at it, again, using some publicly available RNA-seq data, and you can see my wonderful gene X's expression is increased in cancer compared to normal. And then when we looked in our bespoke cohort, you can see that its expression is increasing, going from the tube to the stick, which is that precursor lesion, up to cancer. And I think one of the interesting things, and one of the really interesting things that we got out of this study was by including the normal ovarian surface epithelium as a control, we can see that really if we had done this study a number of years ago before we knew that the tube actually is a cell of origin, we probably wouldn't have identified this gene. If we had used the OSC, the ovarian surface epithelium, as our normal control, we wouldn't have seen the differences. We went on then to look at some tissue, and again you could see this change in expression going from your normal along serous borderline, low grade and high grade, and you really see some really deregulation and overexpression of this gene. So obviously I'm a molecular biologist, so I had to take it back to the lab and mess with it. So the first thing we always do with things is knock it out and then overexpress it. So using siRNA, we've knocked it out of lots of different ovarian cancer cell lines. And basically what happens is the cells die, which is always great for us as cancer biologists. The other thing is then if we take some normal fallopian tube cells and overexpress this gene in it, what we can see is all of a sudden they start gaining all of these key oncogenic phenotypes. They can start growing in anchorage-independent conditions, which is kind of indicative of transformation. They also start to migrate more and invade more. So really, this is told that this gene is really, really important in cancer. But we didn't understand really how it is expressed, and we really couldn't understand its, we haven't been able to understand its potential as a biomarker. So I said, based on all of this, we decided to take this gene forward for a study in methylation. The other approach, as I said, which has been more from Paul Mullen's lab, is to do a methylation array. So basically let the samples tell us where to look. And said we identify, again using this bespoke set of the normal tube, the stick and the cancer, we carried out a methylation array using the Illumina 450K bead array, and we looked for differentially methylated islands. The one interesting thing that came out of this study is that not all the methylation sites were associated with genes, and we did have matched gene expression data for this study, and we thought, you know, you go back to what you study about methylation and you think, right, well, if a gene is hypermethylated, that means its expression is going to go down, and if it's hypomethylated, the expression is going to go up. We actually found very few genes that was the case. So we do think that actually the methylation, there's a lot more to it. Like obviously what we're learning and our understanding of it is a lot more simple, and there's a lot more to learn. So we wanted, now that we've identified potential CPG sites or potential genes to go after, we obviously needed to validate these. So to do this, we took the approach of designing a pyrosequencing assay, which I'll tell you about briefly. We then validated in the tissue from these samples, and then we've also validated them in an independent cohort. So I said this first step is this bisulfite pyrosequencing. So essentially what you do is you treat your samples with this, you do a bisulfite conversion, and this is a way of distinguishing between cytosines that have a methyl group on or not. So when you bisulfite convert it, a normal cytosine, an unmethylated cytosine essentially gets changed to a uracil, while the methylated ones are protected. You then design a PCR around it and sequence it, and basically you look for then whether it's still a uracil or whether it's become whether it's stayed a cytosine. And this is a sort of example of the things you get. It's called a pyrogram, and this is just some data from a study where somebody was inducing pluripotent stem cells, and they just sequence across the promoter, and what you can see is you get a dramatic increase in methylation of this particular gene, which showed that the cells had been reprogrammed. And I said, yeah, that's just the sequencing. So this is the pyrosequencing results from my candidate gene, and you can see again the methylation really is dropping significantly. So it really has validated that we do think this gene X is being controlled by methylation. We also took forward about eight potential CPG sites from the array, and all of these we predicted would go up through cancer. So unfortunately 3 of them went down, and we don't know if this is technical issues, that basically when you design these pyrosequencing assays you don't always get a chance to completely overlap with the probe, or whether it's just science. But the other 5 all did go the way we anticipated, and we took forward these 3 given their statistical significance. We then went on to test these 4 genes, or these 4 CPG islands, using an independent cohort. So this is data from 45 normal fallopian tubes versus 45 high-grade serous, and this is all FFP tissue that we accessed through the Northern Ireland Biobank. The important thing about these normal cases is actually they were all undergoing surgery for other gynecological situations. So these are the sort of cases where CA125 often can be elevated, or maybe there is questions about whether there is a disease there or not. And what was really nice is that in this independent cohort, all 3 genes, or all 3 CPG sites, have very nicely validated in this independent cohort. And again, when we broke this down by stage, all of them showed that they changed at a really early stage. So this means we really do have potential application to a screening scenario. Obviously, with all things, we have to compare them against kind of the gold standard. So we have compared them against CA125, and this data was available from the clinical notes. And you can see here when we've performed a ROC analysis and got our sensitivity and specificity, all of our potential CpG methylation sites have better, if not equivocal, sensitivity. But you can especially see here for my favorite gene X, the specificity is actually really, really good. So we do think that there's real potential for these biomarkers for ovarian cancer. We're not saying they're going to replace CA125, but we do think they can be used in conjunction. So now the hard part, making it actually a liquid biopsy test. How are we going to do this? So I suppose things you need to think about is how much DNA do you need? What is the best assay? And also the other really important thing is to think about the methylation status in blood. Because this is obviously, if you're going to be accessing it in blood and there's going to be lots of blood cells around, there's going to be lots of DNA from other samples, we need to make sure that you can actually see the woods for the trees. When you think about how much DNA, it's how much DNA can you actually get from plasma and how much is actually methylated. As I said, there is no standard way of isolating your ctDNA or your cfDNA. There are multiple kits available, but you can see there is really a huge range in what you can get back. And our own experience, from biobank samples is not a huge amount, but there is improved methods coming on that you can put in more and more DNA or more and more plasma. The only issue is that you have to be careful of blood-based PCR inhibitors. Whether this is applicable to early diagnosis, we have to think about how much DNA is out there. You can see here, if we work back from a small tumour, we do think it's possible. We do think that there could be about 17 to 20 tumour genomes present, which means we should be able to detect going down to our limits of detection, but that assay needs to be very specific. We need to think about different assays, and all of these are quite specialist. We have the methylation specific PCR coupled with digital droplet PCR. Other things like cold PCR, they're also known as fast cold PCR, ice cold PCR. So there really is a lot of technical advancements that we still need. So really, in summary, I want to say that we do have great potential for liquid biopsies to be applied to personalised medicine. And I do believe methylation DNA is a very strong candidate and innovative biomarker. But it's going to be the translation of this to the clinical setting is going to take time, and we really do need the right clinical cohorts to test all of this. So finally, I just want to thank everybody in my team, obviously Paul Mullen's team, our funders, and obviously the Northern Ireland Biobank who've played a huge role in this. So thank you.